Good evening, everybody, and welcome all of you to the live program number 141 at Orthopedic Principles. Today, our guest of honor is Dr. Karthik Karuppaiah from King's College, London. Mr. Karuppaiah joined as consultant in King's College, London in 2014 following completion of his advanced training in shoulder, elbow, hand, and wrist surgeries. He completed his orthopedic training at King's College, London, and also at Ganga Hospital, India. He was trained in various hospitals in Southeast London and Northeast England. He completed his master's degrees in orthopedics from the Teesside University, UK, and also from the Madras Medical College, India. He's also a member of the Royal College of Surgeons. He holds a master's degree on evidence-based medicine in orthopedics. He's also a faculty member at the King's FRCS Intense Revision Course, Hand Surgery FRCS Revision Course, and the Medway Upper Limb Course. And he's also a clinical and educational supervisor for the foundation year and specialty training doctors. Today, it's my great honor to introduce you to Dr. Karthik Karuppaiah from King's College, London. Over to you, Karthik.
Thanks very much, Hitesh and Sindil. Thanks for organizing this. Welcome everyone for tuning to this. I'm one of the upper limb surgeons based in King's, like Hitesh has told. So my talk is on total elbow replacement. I have no financial disclosures that would be a potential conflict of interest with this presentation. So the talk is going to be divided into 6 sections. So we are going to start with the evolution and the biomechanics, which essentially is intertwined, followed by patient selection, surgery, a bit of literature review, complications, and then at the end I will give a brief summary of where we are now with regards to total elbow replacement. So if you look at the evolution of total elbow replacement, before 1970s, most of the surgeons used either excision arthroplasty, interposition arthroplasty, or arthrodesis of the elbow for a lot of conditions like infection, post-traumatic conditions, arthritis, etc. The resection arthroplasty was first described by Park in Liverpool and Morrey in France in 1780s, which involves excision of distal humerus, articulating surface of the ulna, and the radial head. The problem with this surgery is it produces a lot of instability in the elbow. A lot of patients find it very difficult to use the upper limb once you have done the excision arthroplasty. It does give a good pain relief, but it comes at the expense of instability. 100 years later, to avoid this instability and to reduce pain, increase range of movements, De Fontaine described interposition arthroplasty, where a bit of the articular surface is excised and interposed with either fascia, fat, or other spaces like rubber, nylon has been used in the past. So this is mainly done to give pain-free movement and at the same time to maintain stability. And it's been commonly used in young patients with the painful elbow conditions. If you look at the picture on the top left side, that was the original excision arthroplasty which was described, where there was a V-shaped osteotomy of distal humerus, ulna, bit of radial head has been excised. So that gives a bit of space where you can interpose the tissue, which will give some painful range of movement. However, it can cause a bit of instability also. So the modern techniques involve removing just the articular surface and then stitching the graft jacket with the anchors to the front of the elbow and to the back of the elbow. Sometimes we can use a distraction osteogenesis to help the graft to heal to the surface and then let the patient to mobilize the elbow. To the top right is a patient who had a ankylosis, which was treated with excision arthroplasty and interposition with graft. If you look at total elbow arthroplasty, before 1970s, it was in a very primitive stage. So the first total elbow arthroplasty was based on the experience of hip arthroplasty, where Jude, I'm sure we all know Jude views of the pelvis. So Jude started using this plastic, which is nothing but acrylic resin, to replace the femur head. Jude thought that this prosthesis is biocompatible, doesn't cause any issues with the tissues, or normal soft tissues of the hip. So following Jude, plenty of surgeons started using this plastic, which is nothing but the acrylic resin, which has been used nowadays in the nails, paints, etc. So they started putting this acrylic prosthesis in the elbow. This is a very interesting paper where Jerry used one of the acrylic prostheses for radial head fractures. And if you read the article, they did it mainly to prevent instability, number one. Number two, to prevent the migration of the radius, especially in the Essex locus lesion. So at the time, in addition to this plastic, which is acrylic resin, which has been used as elbow replacement prosthesis, plenty of other things which has been used, like proximal ulnar metal resurfacing, which was done by Bickel and Peterson, and metallic distal humerus replacement done by Street and Stevens. It's not just that. There's plenty of other materials like nylon, vulcanized rubber, which has been used for elbows. All of them failed because the prosthesis become unstable and loose. This is a very interesting slide where you can see that even in 1940s and 50s, people have used a hemiarthroplasty for distal elbow. And there is a prosthesis on the left which goes like a clamp, holding the humerus and the ulna to give a bit of stability and a bit of movement. And on the right is the distal humerus resurfacing. So these were used in the past, but none of them lasted well. It's mainly because all these prostheses needed some stability in terms of cement. So there was no cement used, so most of them dislocated, dislodged. The era of modern total elbow replacement started in 1970s, and this coincided with the Charnley's low friction total hip replacement. The first proper total elbow replacement was introduced by D. This was in 1972. He used it for rheumatoid arthritis patient. The problem with this prosthesis, it's a fully constrained prosthesis. A fully constrained prosthesis has a metal on metal hinge, which is fixed to the bone with cement. The problem with these fully constrained prosthesis is all the stress is directly transferred to the bone prosthesis interface, which led to a lot of aseptic loosening and prosthetic failure. The picture on the right shows the Stanmore prosthesis where it has broken the humerus and has come out because of the aseptic loosening. If we want to know why these prostheses failed, we need to know about the biomechanics of the elbow. In the medical school, we were all taught that the elbow moves like a door hinge, which essentially means both the elbow and the knee moves like a door hinge, which essentially means there is a single axis over which elbow flexes and extends. So that's exactly what was taught in the medical school, and most of the prostheses were designed based on this principle in the early 1970s. However, if you look at the elbow flexion extension axis, it actually goes through geometric center of capitulum and geometric center of trachea glue. It's around 4 to 8 degrees of valgus with respect to the long axis of humerus, which gives you the carrying angle. But if you look at the axial view, it's also internally rotated by 5 to 7 degrees with respect to the epicondylar axis of the distal humerus. So this is unique in the elbow when compared to other joints where the articular surface is rotated a little bit when compared to the long axis of the bone. In addition to it, if you look at the trachea, the capitulum is a bit of a symmetric bone, but the trachea has a little bit elongated lip on the medial side in this coronal plane. But if you look at the axial view, it's not that elongated. So the shape itself is not very symmetric. And when they try to find out the axis of rotation in the humerus, it's not a fixed line because of this different shape. So to the picture on the right side, you could see that in the coronal plane and in the axial plane, the center of rotation moves by around 2 millimeter for the elbow range of movement. So it shows that the elbow is not a uniaxial joint. It's not a perfect hinge since the center of rotation keeps moving at different position of the elbow. This is another interesting paper where it showed that in addition to the change in the center of rotation axis in flexion extension, the forearm also rotates internally during the early part of flexion and externally during the later part. This is again due to the shape of the trachea. And this is actually my arm. You could see when I'm extended, my palm is a little bit internally rotated. When you flex it fully, the palm goes for a little bit of external rotation. And this is my daughter's hand. So I asked her to flex it, extend it. She goes for a little bit of flexion, and you could also see quite a bit of a carrying angle, which is typical of the elbow joint. So the ulna also internally rotates with the pronation and externally rotates with supination. So it's not just flexion and extension, it also rotates a little bit. And the flexion extension axis varies depending on your forearm pronation. If you try to flex your elbow with the forearm fully pronated versus fully supinated, the flexion extension axis varies in the distal humerus. And when the arm is moved passively without any muscle activity, the flexion extension axis is different when compared to the arm when it's moved actively. So it all shows it's not a perfect hinge. It's either a loose or a sloppy hinge joint, or the elbow is a loose or a sloppy hinge joint. So what happens when we put a fully constrained prosthesis like Stanmore prosthesis or Dees prosthesis is excess force is transmitted to the bone cement interface from the prosthesis, and that would have been normally transferred to the soft tissues, which lead to the prosthesis loosening. So this is the first issue in the old prosthesis where the force is transmitted directly to the bone implant interface because it's not biomechanically designed. The second reason is if you look at our joints, all of them, you can classify them based on the lever. I'm sure we all have read this in the school. So basically the first class lever, the fulcrum is in the middle and it's a good lever. The second class lever where the fulcrum is one end, load in the middle, that's an excellent lever. So that's what you have in your ankle, so you can run for longer. The third class lever is the least efficient lever. That's the elbow, because what you have is a hand, which is, share the next slide. So what you have is the hand with a weight and your biceps acts near the fulcrum to try and lift this weight up. But there's a huge lever arm. In addition to it, there is a gravity. So if you look at the joint force, joint reaction force, because the biceps acts from here, what happens is there's an enormous amount of force that goes through the elbow joint. There are studies which shows it could be around 20 times the force what you have in your hand. However, since it's a least efficient lever, because it's trying to pull it here rather than from that, the weight that passes through the joint is quite a lot, which is transmitted to the prosthesis and to the bone, which could lead to loosening. That's the second reason. The third reason is, if you look at the elbow is primarily stabilized by a lot of ligaments. I'm not going to do a lot of details about this in the lecture today, but it has medial ligaments, lateral ligaments, capsules, and also it has a lot of muscles like flexor origin, common extensor origin. It has brachialis, biceps, triceps. So what happens is there is a little bit of play in the joint and a lot of force is captured by these soft tissues around the elbow. When you do a fully constrained, these soft tissues doesn't work at all. So a lot of load transmits through the prosthesis to the bone. So these are the three main reasons. Like it's not uniaxial, it's polyaxial. the least efficient lever arm, because the elbow biomechanically is a third lever arm. And the supporting structures doesn't take any load. So that's why the fully constrained, the yearly prosthesis failed within a period of years, or become less popular. If you look at the types of total elbow replacement, other than the fully constrained, we have two others. One is linked, which is either semi-constrained. The other one is unconstrained or unlinked prosthesis. There is another group which is recently been used a lot, where you can decide intraoperatively whether you want to link it or unlink it, depending on the patient's soft tissues, bony anatomy, etc. Unlinked total elbow arthroplasty. So what happened after fully linked started failing a lot? All the surgeons went to the extremely opposite side, which is the unlinked total elbow arthroplasty, where there is no link between those two prostheses. The load is shared between the prosthesis and the soft tissues. The most important bit in the unlinked total elbow prosthesis is the patient should have a good ligament, good working muscles, and a good bone stock. So if they don't have any of this, this unlinked is not going to work. They will end up with an unstable elbow, with a dislocated elbow, actually. And in addition to it, in unlinked elbow arthroplasty, it's quite unforgiving. If you put the component precision in different, rather than the anatomical place, there is a more chance it can dislocate or wear off and loosen. Since the weight is shared between the prosthesis and the soft tissues, the aseptic loosening in unlinked is far less than the other varieties, and also the wear is less if it's done properly. The commonly used unlinked prosthesis is the suture strap type 1. It has a humeral flange that projects into the capitulum and into the medial epicondyle. It's made of vitalium and the ulnar component made of polyethylene. I have used it when I came to UK. I've seen people using it a lot for rheumatoid arthritis, which in the last 5-6 years, very few people use this. I'll tell you why. The other unlinked prosthesis is for patients who have unicompartmental osteoarthritis, like someone who has osteoarthritis just affecting the radial head and the capitulum, but the ulnar humeral joint is intact. In those patients, you can use unicompartmental replacement, which is lateral replacement elbow, and it has a good, there is a lot of studies showing a good outcome with these replacement. The other unlinked prostheses, which you can see in the literature, are Type and Kudo, Pritchard, capitulocondylar, Roper tube. They are not done in large volumes, even though there are pockets of surgeons doing it. They are not done in large volumes, so we don't know much about these prostheses. Next is the semi-constrained. In the semi-constrained, the commonly used are Conrad-Morrey and Discovery. The other ones were used in the past. Still few people use it, but not much. The most important advantage of semi-constrained or the linked prosthesis is that it broadens the indications of total elbow replacement dramatically, because you can use it in patients who have bone osseous deficiency, the patients in whom the ligaments are not working, the patients who have significant deformities because of non-union, bone loss, or whatever it is. This is a game changer when it was introduced, actually. In the semi-constrained variety, the prosthesis is linked with the pins and bushings, which is made of plastic, polyethylene. And they are usually designed as a loose hinge design, which means it does allow a little bit of movement, but not a lot. So they also, a lot of them have an anterior flange because it's a bit loose hinge. They have an anterior flange to prevent, to increase stability, to prevent rotational instability. Again, since it's linked to some extent, the commonest reason why they fail is because of aseptic loosening, that is the bone or the cement bone interface. The other reason could be the wear of the poly in the bushings. So this is the design which the sloppy hinge prostheses or the linked prostheses have, where it allows varus valgus movement of around 10 degrees. It also allows a 10 degree of rotation. So what it does is when it moves, a part of the load is transmitted to the surrounding soft tissues, to the ligaments and the muscles. So it reduces the load transmitted between the bone prosthesis or bone cement interface. Conrad-Morrey, you could see the evolution over a period of around 35 years. They keep changing. It's because we still don't have an ideal implant for the total elbow replacement. These are the other linked prostheses. The Discovery is the one among these three which has been more commonly used next to Conrad-Morrey, which has similar design like Conrad-Morrey. These are the newer implants which has been increasingly used. I don't have much experience in them, but logically they work extremely well in a complex elbow issue. For example, the Latitude prosthesis, it has unlinked implant, which is on here. You can do a radial head also. And if you want to link it, you have to just put the cap on the top, and that will make this implant a linked implant. You can do the linked or the unlinked without the radial head, or you can do a hemiarthroplasty. Similar to that, the DePuy has a claim. So the good thing about this convertible total elbow replacement is one implant that caters to everything, like linked, unlinked, hemiarthroplasty, and the surgeon needs to be familiar with just one technique, less equipments, the theater staff is happy. The surgeon could make a decision intraoperatively to link or not based on how bad the soft tissues and the bone is. And the worst case scenario, you put in a linked, unlinked prosthesis, it dislocates 6 months down the line. You just go in and then make it linked by putting a small cap into it. It's not a major surgery where you need to remove the humerus and the ulnar components and then link it. It's very straightforward. If you want to learn more about the implant design, this is a lovely review in JBJS, which you can read. And then we move on to patient selection. So the indications for elbow replacement if a patient has osteoarthritis, rheumatoid arthritis, where 60% of the patients could have elbow involvement. Recently, there's a lot of patients who, with the complex intraarticular fractures, the patients who are elderly having complex intraarticular fractures, where you can't reconstruct it, you could do elbow replacement, which we'll discuss a little bit later. And you could do for complex non-union, there is an unstable elbow, and obviously in tumors. Where you can't do it is if there is infection, the soft tissues is poor, the bone has neuropathic joint. If the patient has poor muscle function, and the patients who are unreliable, which means essentially they can't do the weight restrictions, it's not a good idea to do elbow replacement in these patients. The most important thing before doing elbow replacement is to tell the patient that they can't do any heavy work or manual labor after the surgery, number one. And if they want to load the elbow, they can do a repeated loading of less than 1 kg, and they can do a one-time loading of up to 5 kg. That's the limit. You have to tell the patients very clearly this before the surgery, document it, and then put it in the consent form. Also, we have to tell the patients not to force pushing and pulling even of the dose. So with regards to the choice of the implant, again, it depends on the surgeon preference. More than that, what the patient need in terms of how the joint is, whether it's unstable, what is the range of movement the patient has, and the degree of pain the patient has. Currently, if you look at any joint registry, more than 95% of the joint replacements are linked implants, which is semi-constrained. Okay, let us move on to the surgical technique. So there are two, with regards to the position, you can put the patient on the lateral or on the supine position. I personally prefer supine if it's osteoarthritis or rheumatoid arthritis, where the elbow is fine. If the patient has instability, and if the patient, it's a dislocated elbow or fracture, I prefer lateral position. I don't have a scientific reason behind it, but that's what I prefer. With regards to the supine position, the good thing is you can flex the elbow fully and then see the joint very well when doing the surgery. You can get a view like this with the supine position, but with the lateral position, you might struggle to get this view. Incision is typically posterior midline incision. Try and use the previous incision when possible. If you can't, then leave at least a 4 to 5 centimeter gap between the previous and the current incision. So once you have incised, the most important thing is to find the ulnar nerve. I tend to find the medial part of triceps, and your ulnar nerve is always there. You find the ulnar nerve, release it liberally till the from almost distal third humerus to the proximal ulnar. Some people don't release the nerve, they release do a bit of limited release and restore the nerve back to the original position, but I don't do it. So once you have done that, then you have 5 options in approaching the elbow joint. Either you could do a para-tricipital, which means you go on either side of the triceps. You can go lateral para-olecranon approach. You can go tricep splitting or transmuscular approach, which is commonly used in fractures. Or you can use a triceps tongue approach or triceps reflecting approach, whichever one you prefer that day. So this is the para-tricipital approach, where you could see a cuff of triceps attached to the ulnar, and the remaining is retracted on either way. So you could see a good bit of your distal humerus and the ulnar. It's a bit of a struggle, but you preserve the triceps. That's the advantage in this approach. You can try it in fractures, but not for primary total elbow. The other one is the lateral para-olecranon approach. Again, it's pretty much similar to the previous one. However, it's not, you don't do a lot of dissection on the other side, actually, on the medial side, other than getting the nerve out. So you can have a look at the video of this approach in the OTA website. It's a good video, and it's like 8 minutes. It's good to see how you can get a good view of the joint with just a lateral para-olecranon approach. There's one more. The last but one is the triceps tongue approach. Sean O'Driscoll does this for the elbow replacement. He has a video in the MUID. If you want to watch, you can watch. It's just a triceps tongue. You take the tongue off, do the replacement, and then put it back. This is the approach which I personally use, which is Bryan and Morrey's approach, where the first step in this approach is to find your ulnar nerve, and you cut the medial intermuscular septum and move the ulnar nerve anteriorly. So if you don't cut the intermuscular septum, medial intermuscular septum, it's very difficult to transpose it properly. So you cut it, remove 1 or 2 centimeters, and then move the nerve anterior to the medial epicondyle. Once you have done that, then actually the approach starts from the medial triceps along the medial joint line, capsule, fascia over the FCU, periosteum on the ulnar. You lift everything as a flap. There's a slight modification in a sense, like in very thin patients where you can't get a decent flap of tissue, you can always take a chip of bone from the tip of olecranon along with the triceps, and it's easy to repair it. So once you have removed everything to the lateral side, then you take remove a piece of the tip of the olecranon, and you see the elbow joint, release the capsule and the collateral ligaments, medial ligaments. After which, once you have a good view of the distal humerus, this is an important thing where you have to release the anterior capsule. And the most important thing is to just use your periosteal elevator to roughen the surface, because this is where your cookie is going to, you're going to put a bone cookie behind the flange when you do your elbow replacement. So you have to roughen that area quite a bit. Once that's done, you should get a view like this, where your ulnar nerve is protected and it's anteriorly anterior to your medial epicondyle. You could see your humerus, radius, and ulnar very well. I'm not going to go through the surgical technique, well, but I will just tell you the important steps in each important thing which you need to remember when you're doing each steps. So when you do the condylar cut, the most important bit is to save the bone. Tell your nurse to keep it so that you can put it as a cookie at the end. If you don't tell them, when you need it, which is at the end of the surgery, the bone may not be there, and you might find it difficult to find something else to put it there, number one. And when you are putting the prosthesis, especially when you're reaming and all those things, you need to get a hang of where you are putting the prosthesis. So for example, for the anterior posterior placement, you need to get a good idea about where the anterior cortex is. And your flange has to sit on the top part of the coronoid fossa. And for the axis of rotation, we see the posterior plane of a medial and the lateral column. So that's where you get your axis of rotation. So these are the things you need to be aware when you start reaming or putting the jig on. And when you put the, once you have prepared the humerus, you put the trial prosthesis with the cookie on, so that when you put the original prosthesis, you know which bone chip you're going to use, and it's easy to insert it rather than you struggling at the end. Next is the preparation of the ulna. When you prepare the ulna, the most important bit is to widen the entry point with the burr. And resect the tip. So don't compromise on these two. If you compromise on these two, you will struggle. It will take hours for you to get the right size prosthesis into the ulna. So widen the entry point. And then cement is extremely important. So if you do good cementation, the risk of aseptic loosening is less. So proper cementation is extremely important when you do elbow replacement. This is very important, especially with the Coonrad-Morrey, where you have to clip the pin. The pin goes there and then locks it. So if you don't lock it when you put the prosthesis in, it's not the end of the world. 3 weeks down the line, you will see something like this. And then a few months down the line, you will see something like this. And you have to go back in and then put the clip back. So it's always better to make sure it's clipped properly when you use the pin-to-pin mechanism. So this is a good technique where you know the implant. So these are the pins. So this is the one which goes and clips into it. So you have the bushings which come on either side, and this into the ulnar prosthesis, which actually gives the sloppy hinge. And you can put your bone graft with a couple of threads which come on either side, so that when you insert, it stays exactly where you want it to be. And this is how it clicks in. This is the most important step when you do the elbow replacement, because you put the cement in the humerus, after which you have to do all those things. So you have to then insert your humeral component with the cookie on. Then you align it with your ulnar prosthesis. Then you put the pin, lock it, and then you hit it. So this is you will have a minute or two for you to do it. So you need to be a little bit on the top to do this, or else it's going to be struggle for you to do it if you leave it a little bit longer. I don't hit the prosthesis. What I do is I just straighten the elbow once the pin is clicked in. So that gives the right tension and right amount that the prosthesis gets pushed into the humerus. I don't hit it with the pusher. Once that's done, it's closure. So you do a X-shaped hole and a transverse hole. You have to do it at different planes in the ulnar, or else what will happen is it can easily break the bridge between the holes, because we use fiber wires that are quite strong. This is the technique. So once you have repaired the triceps, I tend to do a subacute transposition of the ulnar nerve anteriorly, and then close the wound in layers. So the most important thing when you do the surgery is to save the cookie to start with, get the rotation, the alignment right, take your time to prepare the ulnar. And this is something when you start doing elbow replacement, do 2 separate mixes. The first one for the ulnar, you get the prosthesis fixed. And once the ulnar is fixed, then you do another mix for humerus and then do everything. Once you get a hang of it, then later on you can do in one mix. With 2 packs in one mix. Don't forget the cookie when inserting the humeral prosthesis, which a lot of time we do. If we do, then it's a bit of a struggle. We can always insert a small piece of bone into that. Lock the pin, and we have to repair the triceps and transpose the ulnar nerve. I have done very few of the neck cell. So this is an example. This is slightly different to the Conrad-Morrey, which is the newer version of it. With regards to the rehabilitation, leave the patient in a bulky dressing with the elbow in extension. I let them mobilize as tolerated. I remind them they can't lift more than 5 kgs and repetitive loading less than 1 kg. And also put them on extension splinting for 6 weeks, especially in patients who have osteoarthritis, because they are the one who lose extension. Let us look at the outcome. This is just a literature review. This is an excellent paper, actually, which is a prospective RCT where they compared total elbow arthroplasty versus ORIF for distal humerus fracture. This is from McKee in Canada. So what happened is they had around 20 patients in each group. When they did the surgery, around 25% of the patients in the ORIF group, the fracture was so smashed up, they have to convert it into a total elbow arthroplasty. The operative time obviously is less in total elbow arthroplasty group, which is expected because in ORIF you have to do a olecranon osteotomy and then fix it and then fix all the olecranon at the end. The interesting bit is the outcome is better in the total elbow arthroplasty group, and also the flexion extension arc is good in total elbow arthroplasty group. The most important bit is the reoperation rate in arthroplasty group is only 12% when compared to the ORIF group, which is around 27%. And this is in the elderly patients, actually. This is again almost a similar paper, just to validate the previous one, where they did the surgery for a woman more than 65 years, and they got excellent result with the total elbow arthroplasty. This is a very interesting paper from Mayo Clinic. So what they have done is they have done a total elbow arthroplasty, and then they followed up these patients for longer duration, around 44 patients. And then they found that the survival rate for patients without rheumatoid arthritis is around 92% at 10 years, which is amazing compared to what it was 10, 20 years back. And with regard, if a patient has rheumatoid arthritis, the survival rate reduces to 76% around 10 years. And again, the risk factor for revision was male sex. Probably they used the arm a little bit more for heavy work. This is again meta-analysis published in JOT, which analyzed the patients who had total elbow arthroplasty versus ORIF for distal humerus fracture. And they found that they both do really well, even though the complications on the reoperation is more in ORIF. This wasn't statistically significant. At least this gives a bit of idea that total elbow arthroplasty is a safe option in elderly patients with the complex intra-articular fractures. If you want to know about the technical tip, surgical approach, is a good paper from Ali from north of England. There's a Delphi study to decide on who will benefit from an elbow arthroplasty straight away, which patients with the distal humerus fracture will benefit from elbow arthroplasty. So the study shows that the non-rheumatoid patients more than 75 years, or rheumatoid patients with the rheumatoid elbow disease any age, if a patient has pre-existing arthritis, age more than 60 years, anyone with reduced life expectancy or any pathological lesions in the humerus, they will benefit from total elbow arthroplasty straight away rather than ORIF. Recently, there's a lot of interest in elbow hemiarthroplasty. Elbow hemiarthroplasty is not something new for distal humerus fracture. It's been done for the last 80 years. The recent one is the Latitude, which a lot of people use for distal humerus fractures. I haven't used one. So basically, there are concerns regarding the need for further surgery, risks of instability. There's a RCT which has been registered in Denmark. I hope the results of the RCT will give a bit of idea about whether hemiarthroplasty is a better option or not. It's mainly because in the shoulder and a lot of other joints, a lot of us are moving towards total joint arthroplasty rather than hemi in shoulder and the hip. So I'm a bit skeptical about it. So if a patient is obese and they have elbow issues, this is again an excellent paper from Mayo Clinic where they looked at the patients whose BMI is more than 30 versus the BMI less than 30. So the 10-year survival rate is a lot less in obese patients when compared to non-obese patients. It's mainly because the revision rate is quite high and the mechanical failure rate is quite high. So the author suggested that we should tell the obese patients whose BMI is more than 30 that the risks of revision is quite high if they're obese. For rheumatoid arthritis, again, plenty of studies. This is one of the recent and a long-term study from Mayo Clinic. They had around 435 patients. The mean follow-up is around 10 years. It's good to see that the survivorship is around 92% after 10 years after Contraindications replacement in rheumatoid arthritis patient, and around 83% in 15 years, 68% in 20 years. Though a lot of patients had bushing wear, only 2% needed revision actually. 11% of the patients needed component revision, 10 for infection, 39 for mechanical failure. If you look at the processes which has been used extensively for rheumatoid arthritis 10-15 years back, which is Sauter's prosthesis, the survival rate at 10 years is around 70% when compared to Coonrad-Morrey, which it has around 92%. So that's why a lot of people are now moving towards linked prosthesis even for rheumatoid arthritis patients. Osteoarthritis, again, it's not that common, the primary osteoarthritis patients turning up and having a elbow replacement. If you look at the Mayo Clinic, over a period of like 25 years, they did around 20 patients, of which 25% failed. Though the patients have a good functional outcome, they do end up with loss of extension. This is a systematic review and a meta-analysis on comparing rheumatoid arthritis versus post-traumatic conditions for elbow arthroplasty. What they have found is in rheumatoid arthritis patients, the risk of infection is slightly higher. in osteoarthritis patient, the risk of mechanical failure is higher. However, in the longer term, they analyzed like 700 versus 200 patients. There is no significant differences in range of movement, functional outcome using DASH, incidence of infection, or ulnar neuropathy. However, the rheumatoid arthritis patients had better Mayo elbow performance score when compared to the osteoarthritis patients. A couple of landmark papers. These are old papers. This is just for exam purposes. So this is one of the game-changing papers which was published from Mayo Clinic in '98, where they showed the survival rate for their prosthesis to be around 92.4% at 10 years. And at the time, most of the prosthesis, the survival rate was around 60% at 10 years. So this was published by Morrey in '98. And this is a lovely review from Graham King from Canada. So in 2003, if you look at the number of prostheses which is being used throughout the world, the unlinked is the majority of them are unlinked. Very few linked, and then the sloppy hinge somewhere in the middle. It's like 1/3 of unlinked. Even at the time, if you look at the outcome, the sloppy hinge had a better outcome. The mechanical failure rate was quite high in the flexed hinge group. And again, if you look at in the same paper, the type of prostheses used, the majority of them are Suture's prostheses. A few Conrad-Morrey and Capilla. So majority of them are Suture's prostheses at the time. And if you look at the number of cases, rheumatoid arthritis is like 10 times the post-traumatic arthritis or osteoarthritis. So rheumatoid arthritis was the commonest cause for doing a total elbow replacement when they reviewed around 2003. So in this study, what they found is that they looked at almost 3,600 elbow replacement. They found good to excellent results in sloppy hinge devices than fixed hinge implants. So they thought that the linked implant does better. So that's when people started moving towards linked from unlinked implant. If you look at the UK's National Joint Registry from 2019, last year, you could see that almost 97% of the elbow replacements are linked. They all are Conrad-Morrey, Discovery, Latitude, and Excel. If you look at the number of prostheses which has been done over the last 6 years, actually, the number of replacements done for elective elbow problem has reduced dramatically. So it has gone back to 2013 level, even though the numbers may not be very accurate. And again, if you look at the reason why the surgery was done, the inflammatory arthritis, previously it was 10 times the osteoarthritis, now has become almost equal to the osteoarthritis. It's mainly because of the biologics which is being used in patients with inflammatory arthritis, which does extremely well for them. However, if you look at the replacement for patients who have fracture, it has doubled in the last 1 year. So that's the number which is going to increase over the next few years, and the elective will go down. There's a few cases, some interesting cases with a bit of a message to learn. So this is one of a gentleman who turned up to my clinic. He was 85-year-old. He had this injury almost 5 years back. He had some medical problems, so he was told it's better not to have surgery. So for 5 years, he lived with this. This is his dominant hand. He can't cut any food. He can't use a knife to cut food. He can't brush his teeth. He can't bring his hand to his face or to the head because the elbow is so floppy. He also had minimal ulnar nerve symptoms. In addition to it, he can't even pull his trousers up or do most of his day-to-day activities, and he needed care for a very long time, for almost 5 years after this injury. So he turned up to the clinic. He had a lot of issues. Then, in a sense, like considering his age, we discussed about the risks and benefits, went ahead with the simple, straightforward Contraindications elbow replacement, and this is him at 6 years follow-up. He could do most of his work. The most important bit is previously he used to have carers 3 times a day. Now he's managing just 1 time a day with carer. So the surgery, especially in elderly patients, non-union deformity, they do really well with elbow replacement. This is another interesting case. It's a 76-year-old lady, had a terrible triad injury after a fall. This was treated in a local hospital with a plaster. And then since the elbow was unstable, they took her to the theater, fixed it with radial head replacement. They did mention in the notes that they have done ligament repair, but I can't see any anchors. It could be just a bone tunnel. So she was initially in a cast for 6 weeks, and then some splint for almost 3 months. So even with the splint in this X-ray, you could see the elbow is not in place. And then this is at 6 months. This is at 9 months. And then on 9 months down the line, she ended up in the clinic with completely unstable elbow. Let me see whether I can run this video. Oh. Can you bend it? Sorry, I should have it. How painful is it when you're trying to do that?
It's quite painful, yeah. And plus I got no, when I go to do anything, it's like that, you know, go to switch a light off and that, or do something, it wobbles about.
You
no
can't
control.
Switch on
I can switch it on, but it just feels as if it's flopping about sort of thing, you know.
Okay. So she couldn't drive, she lost her independence, she can't do her hair, she was struggling quite a lot with this unstable elbow with a lot of pain. And this is the intraoperative video, which, sorry guys, I think I have video. It is quite unstable elbow actually. So we did a replacement for her. It was a straightforward replacement. She turns up to the clinic 2 weeks down the line. I think it was 3 weeks down the line. And then she didn't have a sling or nothing. Can you bend it? Straighten the elbow. She had full range of movements. Bend it again. That's good. And can you bring your arm by your side like that? Can you turn it this way? The other way? Do you get any pain when you're doing that?
No.
Perfect. So this is always a worry. When you see a patient turns up to your clinic 2 to 3 weeks down the line without a sling, she drove the car to the hospital, and then she does all the movements in the elbow. And you know, I did explain to her she has to take it easy. And then she comes up 6 months, a year down the line with the humeral component loosening, which is something which has been reported. So she has been using her arm pretty much normally for her day-to-day activities like lifting weights. She was doing hoovering, gardening, all the things. And then the process went loose. We ended up revising. Luckily, there wasn't any cortical breach, so we put a lot of cement and then fixed it. I hope she stays well. She's fine for the last couple of years, but she had a bit of she has restricted her activities now. The another one is this lady had severe arthritis affecting her elbow and the wrist, and her range of movements was quite restricted. So her elbow is almost fixed between 70 to 90. Yeah, this was my first Nexel replacement actually. So basically the Nexel has a very sharp guide wire and a ream. I somehow perforated the distal ulna and then ended up with a bit of cement. Luckily she didn't have any neurological issues. She developed a bit of stiffness. So we ended up taking her to the theater, and at the same time we removed the cement from her elbow. This is another one where you can see within a matter of 6 months, it's a primary osteoarthritis. She has completely eroded her elbow joint. And try and bend your elbow. Your right one, your right elbow, That's fine. Try your left one. Very painful.
Yeah, very.
So other than the pain, what are the other problems you have in your?
Oh, not on that, on its own.
Can you sleep in the night?
Yeah, I sleep with it hanging over the edge of the bed,
Okay.
or on a pillow.
Okay. So she has been sleeping like this for almost 6 months. Actually, she used to put the arm outside the bed and then let it hang. Then only she can sleep. This is in spite of taking all the painkillers. This is her elbow, and then again, you have to listen to her. Try and bend your, straighten it, bend it. Okay, relax. Bring your hand down like that. Turn it this way, other way. Yeah, that's fine. Morning. Do you have any pain in your elbow?
No, the only thing I get is when that muscle, I can feel that's still quite hard,
Okay.
is when I'm trying to stretch that. That's when I get a little niggle,
Okay.
where it's being stretched.
When compared to what it was before the surgery, how is it
That's
now?
fantastic.
Okay. So the pain has completely gone,
Yeah.
and you have got most of the function back.
Yeah, weight-wise, I can't pick up a lot of heavy weight yet.
Okay. So this is the problem with most of the patient. You tell them that you can't lift any heavy weight. And this is like literally 3 weeks down the line after the surgery, who comes and then tells me in the clinic that she can't lift any heavy weight, but she can lift all the, lesser weight. So most of the patients, even though we tell them, what it means is they don't listen to it. And some of them develop loosening. I don't know why they develop loosening. So it's a question mark, big question mark for future research. So with regards to the complications, it's a standard, box standard complications, except for the case some patients might develop triceps rupture, which is around 3 to 9%. There's an incidence of around 5% permanent ulnar nerve injury, transient paresthesia around 26%, which is quite a lot actually. So these are the complications which you see in elbow arthroplasty. Again, this is a distal infection, the wear of the bushing, which led to osteolysis, heterotopic ossification, periprosthetic fractures, both in linked, fully constrained, unlinked, aseptic loosening. Again, this is a Mayo classification of fracture, so metaphyseal and so type 1 and type 2, you probably might end up doing revision. Type 3, you should be able to fix it. Just a couple of slides about revision total elbow replacement. So the outcomes of revision total elbow arthroplasty is quite gloom. So the complications rate is around 44%, and 22% need further surgery. So the outcome isn't great. A couple of articles about revision total elbow arthroplasty. If you are interested, you can have a read. So in summary, since 1940s, there's a lot of innovation in total elbow arthroplasty. The implant design have been made based on the outcomes and the complications which has happened. However, in spite of that, there's still, it's nowhere near hip and knee replacement. So the complications still exist and the current design remains imperfect. That's the truth. So if you read the article, which is at the bottom of this slide, it does say that the commonest reason why the elbow arthroplasty fail is aseptic loosening, which is to do with the prosthetic design. There are no prospective study to compare linked versus unlinked, which will be good in the longer term to decide on which one to use. Sorry. Semi-constrained implants are widely used. Currently, they do give good functional outcomes. So these are my references. Thank you very much.
Thank you, Karthik. Excellent presentation and with a lot of fantastic case studies as well. Just a few questions.
Yeah.
What is the most favored implant in your practice, and does it change according to the pathology?
So I use Coonrad-Morrey. That's the implant I was trained with, and then that's the commonest implant which is being used throughout the world, which is a linked implant. So we can use it both for primary and revision cases. It has the options. However, in complex revisions, you might end up doing a endoprosthetic. That's more like a CAD/CAM design. So most of the straightforward cases you can do with the Contraindications, both primary and revision.
Thank you for that. The other question is, do you consider neuropathic joint to be a contraindication for any of these procedures?
Yeah, I mean, in a sense, like, yes. So the problem with the elbow arthroplasty is the aseptic, which is the bone prosthesis interface or the bone cement interface. So the neuropathic patients, it's very difficult for them to follow the restrictions which we ask the total elbow patients to do, like lifting less weight, reduce repetitive use, number one. And even if they do, they don't, even if the prosthesis loosens up a little bit, they don't usually feel the pain, so it can lead to bone destruction before they turn up to the clinic, which can make a simple thing more complex. That's the reason, nothing else.
And suppose they have some sort of weakness, say a grade 4 power of the biceps or the triceps. Even then, do you think there's a contraindication, or you can go ahead?
You can go ahead, but then you need to be a little bit more careful in terms of how much power they have of the muscles around the elbow joint. You don't want the forearm to hang from the elbow. You need some support to hold the prosthesis together in terms of some muscles holding it together. It's mainly because, again, it comes to the same problem, the loosening. If there is nothing to hold it together, what will happen is keep on stretching, that can lead to loosening of the prosthesis between the cement and the bone.
Thank you for that, Karthik. The other question is, see, you have a master's degree in EBM in orthopedics, and that's really nice to hear. And we have level 1 data on the subject. It's on particular total elbow replacement, linked, unlinked, constrained, semi-constrained. Is there level 1 data? So
most of the papers which I have given, some of them are level 1. You mean meta-analysis? Is that what you are asking?
Even an RCT, a good level 1 RCT.
Yeah. So for example, the paper on for the fractures where they compared total elbow arthroplasty versus ORIF, that's a level 1 paper. There's a few of them are level 1 papers, actually, RCTs, and that was done by centers which is independent of the people who are involved in the manufacturing of the prosthesis.
That is one that compared. Sorry? That is one that compared fractures versus arthritis, is it? What was it?
Yes, yes. Fractures where they treated ORIF versus total elbow arthroplasty.
ORIF versus total elbow.
Yeah.
Okay. Senthil is also in this room. Senthil is a staff orthopedic surgeon from Texas. Senthil, your questions to Karthik.
Karthik, great presentation. So, post-op, do you just put them in a sling, use a splint, or a hinge brace? Well, what's your protocol immediately after the surgery?
Excellent question. So basically, I tend not to send them to physio if I could. So what I do is I give them a sling. Usually, immediately after the surgery, they will be in a bulky bandage. I try to keep them in extension rather than in flexion, because we know in the elbow, they lose extension more than the flexion. Usually they get the flexion with time, but the extension, if they lose it, they lose it. And especially in patients who had osteoarthritis, if I do elbow replacement, I make sure I keep the elbow in extension. And definitely they will get the flexion back with time. So the dressings get reduced in 48 hours. And then I let them mobilize the elbow as tolerated. They'll be in a bit of pain, but I let them mobilize the elbow as tolerated, and then gradually they start using the elbow. So I do see some patients who develop stiffness. For example, the patients where there was a cement extrusion in the ulna, she did develop a bit of stiffness. We have to go back in and then do a bit of release. But most of the patients, majority, more than 90% of the patients without physio, they do extremely well.
And HO is a big problem in elbow surgery. So do you routinely use any prophylaxis?
Not for elbow replacement. So if the patient develops stiffness after an elbow replacement or over-IF, then we will use NSAIDs, but not immediately after that procedure.
Okay. And with all the other joint replacement, hips, knees, shoulders, patient-specific instrumentation, technologies, more technologies coming, what's there in elbow replacement? Navigation, anything?
In a sense, like it's still in the very primitive stage. So realistically, we have got navigation shoulder at the moment. The elbow is still in primitive stage. It's not for widespread use. It's more at the experimental level, actually. Even the robotic assisted surgery are there for the knees, hips, but not at the moment for the elbow. They have started doing some trials in the shoulder at the moment. So yeah, it's at very basic stage.
Sounds good. I don't have any more questions, Hitesh.
Okay,
thank you, Dr.
Thank you, Karthik, for that excellent presentation. Thank you for sparing your time with us, and it was a lovely presentation. It's going to benefit a lot of people all over the world. Thank you so much for being with us. It has been a very great honor, and we really look forward for another lecture later on when you have time.
That's excellent. Thanks very much, Hitesh. That's you're doing an excellent job. Thank you very much. Thanks and help. Cheers.
Thanks, Karthik. Take care. Bye-bye.
Yeah.